Hi guys, it's Sue here, and I thought for our Sunday afternoon conversation that I'm sorry is a little bit belated this week, that we'd really look at the face of shock. And this is just an example. Um, and I hope it's that kind of pulls things together, helps you to see that year by year in the program, course by course in the program, your fundamental sort of foundational courses like anatomy and physiology, and pathophysiology build towards an understanding of how the body works. Your nursing courses really apply our understanding of that as we move along in complexity through the program until we get to points where we really can look after quite complex patients. So let's see how this one goes as we work it through. And for us in high acuity, I'm hoping that as we've moved through the first 3 weeks and up to here to shock, that it really pulls together those concepts from week 1, week 2, and week 3, where we're looking at vital signs and understanding vital signs, where we're looking at arterial blood gases. And what does that mean? We're looking at fluid and electrolytes. What does that mean? So let's start. So let's meet Rebecca. She's a 35-year-old woman brought to the emergency department by ambulance after being found in her home unconscious by her 10-year-old daughter. Imagine how scary that is. Her daughter came home from school and just found her mom unable to rouse her. Recent history of stomach upset, according to her patient's daughter. Now, when we ask her more, and that's why I'm going to give you a little bit more than you initially see here, stomach upset doesn't mean anything to me. Does it mean much to you? So when we ask her daughter, what does stomach upset mean? She says that her mom has been throwing up and has been having diarrhea on and off. She's been feeling really unwell for about a month. She's lost weight and she's had vomiting and some diarrhea for at least a week. The daughter's not sure how long, but for at least a week. Do you see how stomach upset means nothing, but details fill it in for us? On exam, we find that Rebecca's drowsy and really difficult to rouse. If you shake her or call her name, she'll maybe open her eyes a little bit, but very difficult to rouse. Peripherally shut down, and that's an expression that kind of doesn't mean that much for us, but her peripheries are pale. She's got slow capillary refill to her extremities. We see that her mucous membranes are very dry. She's got very deep and sighing respirations and a funny odor. And she's been incontinent. Oh, I'm sorry. So sorry, a typo here. Been incontinent of urine. So a first set of vital signs that the EMS had reported was a temp of 36.9, a heart rate of 130. And remember, we're going to look at our norms and what the relationship between all these vital signs might be. Respiratory rate of 26, blood pressure of 90/60, and an O2 sat of 100. Now, about 30 minutes later from the time that her vitals were last taken, they're repeated, and what we see is the temp remains the same at 36.9. Her heart rate is up even higher at 138. Her respiratory rate is now up a little bit higher at 28. Her blood pressure is down lower. She's now at 80/46. And her O2 sat remains stable at 100. A Foley catheter is inserted. There's 2 reasons you're going to do that in this situation. First of all, she's been incontinent of urine. We don't know what's going on. She's difficult to rouse. We need to determine if there's any kind of toxic ingestion, right? So if we can't rouse her, we don't have enough of a history, we don't know what's going on, we need to rouse her. Or we need to determine what's going on. One of the things we want is a urine for drug screen. So we're able to do that very quickly. Most places you'll have a little cassette that will tell you many of the drugs you're looking for. So they insert a Foley catheter. Remember, even though she's unconscious, we're going to be talking to her. We're going to be assuming consent, but we're going to treat her with the utmost respect, right? So we don't just bear her naked body behind a curtain, even though she's unconscious. We still treat her with the same respect. We only reveal as much as her body is needed for whatever procedure we're doing or for whatever assessment we're doing. That drug screen is negative, but we note when we put the catheter in, 500 mils comes out right away. That's a lot of urine, right? Our bladder usually holds up to about 250 mils comfortably. 500 is a very full bladder, and she'd already been incontinent. We do have some lab results that have come back that were taken immediately on arrival, a set of ABGs and some electrolytes. So let's go through those, and then we're going to work through all of these things. pH 7.05, and we're going to work through them, so I'm not going to go through the norms right now. PCO2 11, PO2 187, and bicarb 6. And the lab calls you with those results as well as tells you they're coming down in the system because they want you to know there's critical results. A few minutes later, you get another critical phone call because the potassium in her lab sample is 5.7. Her sodium is 141, her chloride is 96. Again, I'm not going to go through the norms for a minute. Again, the lab calls you because they want you to know there's a critical lab value, and that's her potassium. And they tell you a really important thing. The specimen is not hemolyzed. The first thing we're always going to ask, if they don't tell us, we're going to make sure that when we've taken a blood specimen and the potassium is high, we want to make sure that those red blood cells have not been traumatized through the blood draw, that you haven't had a difficult blood draw, moving the needle around, trying to get it in, a bruise has formed and you've got those ruptured red blood cells mixed in with some other blood so that it becomes what's called hemolyzed, or you have those ruptured cells. And then because the potassium, which is highest concentration within the cells, now comes outside of the cells because those cells have ruptured, the actual content of potassium, the level of potassium is reported as high, but not accurately high, right? So that because those cells have ruptured and that potassium in that specimen only is high. Okay, so let's analyze these things. And I'm going to try, just so we don't have to keep going back and forth over things, I'm going to try to see, can you see if I put this here? You know what? I'm going to do a different way. Can you stand it if I'm a little bit imperfect here for the moment? Let's try. Hold on a second. Stop share for a second. Okay, it's me. Can you see? I hope so. Is it reading right? I hope so. So let's look at her vital signs. We're not going to worry about the first set. We always would compare the first to the second, but let's just keep things straightforward. Okay, you know what? My daughter is telling me I have to do this a different way. So hold on a second. Hi, you guys. I'm back because my 10-year-old magnificent daughter told me that everything would be backwards for you. And obviously it would. I just didn't know how to work that around. So I'm going back to our whiteboard, and I hope you can see all of this. So here were her vitals: 36.9 for her temp, 138 for her heart rate, 28 for her respiratory rate, 80/46 for her blood pressure, and 100% for her O2 sat. So let's look at them one at a time. 36.8, what do we say? Or 36.9. Normal, 36.5, 37.5. So good. 138, what are we saying? Normal is, remember, 60 to 100. 50 to 60 is a little bit of a gray zone. 90 to 100, we just pay a little attention. So this 138, oh my gosh, look at that, is way up and it's concerning. Let's look at her respiratory rate, 28. What are we thinking about that? Right, normal 12 to 20, and 12 is low unless you're sleeping, 20 is high. Often just on the, so we just keep an eye on it, right? Again, when we're at the edges. So same thing, now I'll try to do a circle more effectively. And so we're way high. 80/46, what do we think? Right, new parameters tell us 120/80 to 90/60, and diastolic and systolic are both low. And I have finally succeeded in drawing a better circle. Whoops, oh my gosh. And low. 100%. What do we think about our O2 sat? Fine. Okay, what do we see? So temperature is fine. Nothing else is compensatory to make the temperature fine. We don't have some kind of mechanism. Well, we can do, yeah, that we're going to see in a basic review of compensatory mechanisms here that's going to affect your temperature. So temperature, we're just taking it out of the picture at the moment, but we're also saying, so fever is not an underlying cause of any mechanism we may be seeing here, or if you had a very low temperature, you're trying to shiver or something. Temperature is not related. Heart rate 138, very high. Now, when we have a high heart rate, does that affect our respiratory rate? Well, it can if we're trying to compensate. So one of the things, when we have a very rapid heart rate, our heart is beating very fast. The only time, and we'll talk about this more in cardiac assessment when we're looking at ECG monitoring, the only time that the heart gets to nourish itself, so 95% of the the time the heart is in service of the body. Everything the heart does is in service of the body, right? Feeding, nourishing the body, pumping for everybody else. The only time that the heart is able to nourish itself, so you have blood that goes through into those coronary arteries and then perfuses across those membrane walls so that you actually have oxygen delivered to that very hardworking muscle. Remember, muscles need oxygen. Those muscles need oxygen, is in that diastole, in that moment of rest, right? So when you're in that systole, when you're contracting so much, you can imagine that that's not the opportune time for oxygen or other nutrients to be trying to get across that capillary membrane. So it's in that diastole, the moment of rest. So when our heart is beating fast, there's two things that happen. One, we have increased oxygen demand. Remember, like you're running really fast, you breathe quickly when you're running really fast. Compensatory, because as we're using those muscles to do that activity, we need more oxygen to nourish those muscles, right? We need more oxygen for that activity. So with a rapid heart rate, we need more oxygen. And at the same time, we have less capacity for that oxygen to get through those capillary membranes, right, to nourish that heart muscle, because that period of diastole, of rest, is so much shorter and so complicated, right? So this is very concerning, a heart rate of 138. And we could have some compensatory tachypnea, so increase in respiratory rate, but not so much, like 28 lying in bed. If I have a tachycardia, you might see a little bit of a compensatory increase in respiratory rate, but still respiratory rate of 28, deep and sighing. No, you tend to, when you're having a tachypnea, have short, quick respirations as opposed to this deep sighing respirations. That's a very typical description of respirations that fall under a different category. So we're seeing two elevations, but I'm not necessarily at this point prepared to attribute them to each other, right? Now I've got a low blood pressure, 80/46, very low. It is concerning because it falls below the parameters. We know that renal perfusion and other kinds of cerebral perfusion, other things may be affected. Blood is shunted to the core when we have a low blood pressure. That's why we're seeing that peripheral shutdown. Now, is this compensatory? Well, remember we talked about this a little bit before. It's hard to know the chicken or the egg, because a high heart rate, rapid heart rate, has a decrease in the efficiency of pumping that blood out. So I'm pumping more quickly. My heart is beating more quickly, but it's not beating as efficiently because I don't have enough time to fill between those beats. Remember, I'm just beating. There's not enough time for those chambers to fill, and I'm constantly expressing that blood, pushing that blood out without enough time to really have an effective cardiac output. So that may lead to a drop in blood pressure, and alternatively, a drop in blood pressure can lead to a rapid heart rate as we try to maintain some cardiac output. So here we have a chicken and an egg. Whoops. And it could be either one, or it could be both. But I know there is a relationship, and the respiratory rate of 28 is a little bit of a wild card. So here I'm seeing a pattern that is, remember, we don't jump to premature conclusions, but I'm seeing a pattern that could be one thing or another thing, right? I could have a hypotension that's leading to a compensatory tachycardia. I could have a tachycardia that's leading to a compensatory hypotension, but I've got the wild card of the respiratory rate. I could have a increased respiratory rate related to either a hypotension, where I'm trying to again get some oxygen at the cellular level, is so critical if we're going into any kind of shock. If I have a rapid heart rate, I maybe breathe. Natural homeostatic compensatory mechanism is to breathe a little bit more quickly, so I get more oxygen because I have greater oxygen demand at the level of the heart. But 28 deep and sighing, that really deep and sighing, does not fit with that picture. So my wild card of the 28 in the middle. So you see, we've got something, we've done a good analysis, but that's not leading me in the only direction. We're detectives, and that's one piece of information that keeps our eyes open, and it starts to focus us. So you know how I like to say what goes in the fine pile, what doesn't? Temperature, fine. I'm not paying attention to that unless I have a change. It's always like, I can always retrieve things from the fine pile. All of these other things are not in the fine pile. Okay, not in the fine pile. It's also of note to me that she has an oxygen saturation of 100% because that is very high. 95 to 100 is normal. it's not that common to see a perfect O2 saturation. And look, I've got a patient who is compromised. Heart rate is tachycardic, blood pressure is hypotensive, excuse me. And I've got this perfect O2 sat, an interesting picture. So I'm gonna just try to get back to where I was. Oh my gosh, it's such a fantastic dilemma here. I think this is, okay, so we analyzed, we did our vital signs. Oh my gosh, but that's only the first start. We also had some ABGs. So are you ready to analyze those? Okay. Okay, here we go again. You see my magnificent writing there, and I apologize for that. We're all just doing our best. This is me. I'm sorry at my best. I look like I'm a senior from Florida, and I'm sorry if I've offended anybody with that, with my glasses that keep becoming sunglasses. And if the hairdresser does not open up soon, Arlene De La Rocha has promised me that she knows how to cut and renew my hair. So you may find that as time goes on, we just sink lower and lower, and I will one day arrive a new me. In any case, let's get on to the ABGs. pH 7.05. Does anyone remember what normal is? It's important. Lots of times I don't care that you remember all of the values of everything. ABGs, it's not a lot to memorize. In this course, I'm never going to ask you to memorize it. In practice, usually when you get a lab result, you're going to see the norms. Hospitals usually do that as a safety check, but it's a good one to know. I think for NCLEX, it would be a good one to know. pH 7.05, and the norm is 7.35 to 7.45. And in fact, 7.05 is getting close to the lethal end. The very bottom of what would be life-sustaining would be 6.8. So this is a very critical ABG, right? Critically low. And do you remember when it goes low, it's acid, right? It's the increase in acid. So it always seems, in my mind, seems like reverse to what I would think it is. There we go. PCO2 11, the norm, 35 to 45. So again, we're way low. PO2 187, we're way high. Is this a problem? We're not talking about COPD, we're not talking about anything, but it's unusual, right? So something is making someone breathe to such an extent that their oxygenation is so high. So they're not having a high respiratory rate for oxygen demand. Does that make sense? It's not, you're not, so you're running and you become really breathless because you have an increase in oxygen demand because you're using up that oxygen with all of that physical activity. So your heart rate may be high and your respiratory rate may be high, but we have an explanation, right? Here we see that the person has a very high respiratory rate of 28, but that person has more than adequate oxygen. So what's driving the respirations is not a need for oxygen. So that's another piece, right? That's another clue to something going on. And then here we go. Bicarb is 6, normal is 22 to 28. So we are way low. Yikes. What are you thinking is happening here? None of these values are normal. My bicarb is low. My oxygen is high. My CO2 is low. And my pH is low. So if I'm seeing any compensation, that compensation is only partial because my pH is not back in the normal range. Do you see any signs of compensation happening here? Think about that just for a second. Are you seeing any signs of compensation? Okay. So let's go back over this because it's really important. Sometimes you think, it's easy to see that I've got an acidosis, right? But what is the source of this acidosis? And if we look at bicarb, bicarb is also low. And you remember, bicarb is going to be low. That's going to be a metabolic process, right? So remember, respiratory system kicks in very quickly for respiratory acidosis alkalosis. A metabolic acidosis alkalosis takes much longer to kick in. So it's really critical that we look at that bicarb. So the bicarb and the pH are telling you that it's a metabolic acidosis, and that O2, that elevated O2 and blowing off the CO2 is an attempt at compensation. So now we start to see, why is she breathing so quickly and so deeply? She is trying to blow off that CO2 so that she can, as a part of that compensatory process. And that kind of respiration is actually has a name. It's called Kussmaul's respiration. That deep sighing respiration that is rapid, and you're trying to blow off that CO2 as part of a compensatory process. So what we see here is a partial, remember it's partial. Excuse me just for a second.
My slinky got stuck on my foot.
Hold on one second. Oh my God, I'm so sorry. So as we all saw, my 10-year-old had a very large slinky stuck on her ankle, and I was not attending to that. I thought she'd go away if I ignored her, and she didn't. And we're back. So I apologize. What a Sunday afternoon. Anybody else living a life like this? Okay. Soon the dog will bark. Soon the garbage truck will come and make so much noise. A package will be here that I have to sign for. Who knows what's going to happen next? So let's get through this. Bicarb is low. Bicarb is metabolic. That adjustment happens, that kind of compensation happens at the level of the kidney. The level of the kidney requires time before that starts. So we have respiratory compensation happens quickly. And we're going to see that with our PO2 and our PCO2. Bicarb is going to tell us about metabolic compensation. We see that her bicarb is low and her pH is low. But we also see at the same time, her O2 is high and the CO2 is low. So she's got a severe, very severe metabolic acidosis because that bicarb is so low. So the underlying cause is that metabolic acidosis. And she is breathing very quickly. Remember I said it was that Kussmaul's reps, breathing very deeply and very quickly to try to blow off as much CO2, because then the respiratory system is trying to compensate for that metabolic acidosis with some respiratory alkalosis, right? Like it's not showing in the page, but that's what it's trying to do, valiantly trying to compensate for that metabolic acidosis. So severe, partially compensated metabolic acidosis. Fair enough? Okay. Now, oh my gosh. Let's go back and see what we're supposed to be doing now. Okay, so we did our vital signs. We did our ABGs. Where are we? Rather than losing our minds. Oh, electrolytes. Here we go. Okay, I'm back. I hope this makes sense. Let's carry on. We have some electrolytes here. And what we've got so far, the lab called us. We've got a potassium of 5.7. They called us to tell us that that's a critical potassium. It's a non-hemolyzed specimen. It's a good specimen. It's 5.7. Sodium is 141. Chloride is 96. So what does that tell us? What is the normal for potassium? Now, it could range, right? Depending on, here we go. It could range, I'm just going to put this here. Oh my gosh. Depending on where you work. So you're going to use the range that is acceptable at wherever you are working to have these lab results. It could be 3.2 to 4.8, 3.2 to 5, 3.5 to 5.2. There's a little bit of variation, but roughly for our purposes, we're going to just try to remember 3.5 to 5, regardless of any scale. There is no world in which 5.7 is okay. 5.7 is way elevated. Sodium, normal 135 to 145, so we're fine. Chloride is 95 to 105, so we're fine. And so bottom line, very high potassium. How are we going to see a high potassium? We're going to see it on a cardiac monitor. We're going to see that on our cardiac monitor, and we're going to see that with those high peaked T's, right? Those really nice, big, high peaked T's, not a elevation that we'd see in an MI, but a big peaked T. That's going to show us a high K. I would always do a 12 lead ECG as well, but even on a lead 2 monitor, we're going to see that. And what does that call for? It's going to call for some immediate steps. It's going to call for an intravenous access, right? So I've got a lock or a line. It's going to call for continuous ECG monitoring, frequent vital signs, assessment, stat assessment by a physician, right? So 5.7 is critical. We're seeing it on a cardiac monitor, and that's because while potassium has many functions in the body, the place that we have the most primary influence and the greatest area of concern is our heart. And it really impacts the excitability of our heart cells. And that impact is then seen on that cardiac monitor, but it's seen then in some rhythms, some aberrant rhythms that we may develop. So it's critical that we manage that potassium. Okay, so now we've looked at everything. We've got a history. We've got some more information. Remember that basic feeling unwell, stomach unwell. For a little bit of time, we asked her daughter more questions, and we found out that she actually has been feeling very unwell for a month, has had a 20-pound weight loss, has had vomiting and diarrhea for at least the last week, and no other medical history. So we found out a little bit more about that. We got some electrolytes that we just analyzed with a high potassium. We've got some vital signs where we have a tachycardia, a tachypnea, and a hypotension. And at first we weren't sure what was going on with all of those, but our ABGs started to give us a little bit of insight into that tachypnea, didn't they? Because we had that severe, partially compensated metabolic acidosis because our bicarb is low, and we know it takes time. So this is a situation that has been brewing, right? It has taken some time for that to develop. And so our bicarb is very low. It was only 6. Our pH is very dangerously low, 7.05. And that very high oxygen, circulating oxygen, 187, tells us that respiratory drive is not by lack of oxygen. It's not oxygen that is driving her to breathe. In fact, that it is part of the compensatory process of her trying to blow off that CO2 in response to that acidosis. So we've got all of that data. We're already seeing that she's got vital signs that are demonstrative of shock, but we don't know what kind of shock we may be seeing. And remember, we're always looking at the beginning of shock. Remember, you might say, oh, 80 on 46G. I'm not sure if that's a process where I'm seeing shock. We are, if we're waiting for blood pressure to be lower than that, then go home, do something else that's fantastic in the world. But nurses are looking for the early signs, and I'm going to talk about that again, those 3 stages. The compensatory stage is when the body is hanging on with all of its compensatory mechanisms, begging you to take note and respond. And that is our responsibility, that early response. Don't throw away that time. So shock, fundamentally, we always think shock is low blood pressure. It's somebody who's unconscious. It's blood coming out of a body. All these other kinds of things may come to mind. From now on, forever and ever, when I say shock, when anyone says shock, you're thinking it's a lack of oxygen at the level of the cell. And that can happen in a variety of ways. But instead of thinking of all the different kinds of shock, there's 3 good ways to categorize. So one is that so if you think of a pump, our heart is like a pump. It's like the engine of a car. And when we have, I apologize, typo, cardiogenic shock, it's the engine is not working. The engine will not turn on. If I want to drive and I want to get gas to go through the system, I want to do anything. If the engine won't turn on, I've got no luck. So in cardiogenic shock, it's a pump problem, an ineffective cardiac pump. We can also have an ineffective circulatory system, and that goes under a bigger category of distributive shock. Now, all of this is under the shock module. Hold on a second, and I will stop my dog from barking. I just apologize so much. Back I am. And we're at the second category of shock, which is the circulatory system for some reason is the problem. So the pump, the heart is working. I've got enough fluid volume, but I'm not, there's something wrong with the circulatory system. And this falls under what we call distributive. Think about, I'm trying to distribute the fluid that I have. My pump is working, I have enough fluid to distribute, but I can't do that. And often we think of that, the vessels become too big. I lose tone in my blood vessels, and they become so loose that even though my pump is working and I have enough fluid, I can't fill them to actually have tone to move it around. And a good example would be you're trying to put out a fire and you've got this big fire hose that you attach to your kitchen sink. No matter how much water I could get out, if I had a small hose, I could probably put out, no matter how much water I turn on, that hose is so big that I can't fill it in, and it's ineffective. I can't get it anywhere. So there are three actual categorizations or types of shock that fall within this category. Anaphylactic shock, and you know that's an allergic reaction that is life-threatening. It leads to an anaphylaxis. Neurogenic shock, which is a very specific kind of shock related to our brain and CNS. And septic shock, which is one of the most common shocks that you'll see in a hospital. So septic shock, all of those affect at the within their sort of basic physiological process. That's the circulatory system. So you have an ineffective circulatory system. Three different kinds of shock, and they're all each different with different finesse, but understanding the basis is the circulatory system. And so we label all of those under distributive. And then finally, we have inadequate blood volume. So that can be hypovolemia from a trauma and from other cases. And what we think of that as though you've got a car, let's say I've got, my engine is working, all of my hoses and everything are working, but I have no gas. So the car is not going to go anywhere because I have no gas. Okay, so empty tank. Just a quick reminder, that's all in the shock module. 3 stages of shock. I'm going to just put them all here. Compensatory, this is the stage that is critical to us, right? It's specific to each kind of shock. How we recognize each kind of shock, there is some finesse in recognizing it, and that's why it's so important, right? That we understand the early signs and how they may be different. The priority is always to treat the underlying disorder. Do you remember I said that even when we look at distributive shock, there's 3 different kinds that fall under. Even though we understand sort of the basis that the problem is distributing, it's a problem with the vessels and distributing, you know, the adequate volume with our good pump through our circulatory system, we're not able to do it. Recognizing which of those shocks we are seeing and how we would respond is critical. And then again, homeostasis. Our body is magnificent in that it has all of this redundancy, all of these mechanisms that enable us to respond to different situations. We move from compensatory, that compensatory stage, which can be shorter or longer, to progressive and irreversible. Just one second, guys. I'm not going to talk about that here. I talked about those in the shock module. But just to recognize here, what I want to really look at is compensatory. The irreversible is irreversible and your patient's going to die. Progressive is largely a real difficult, you're going to have real difficulty bringing your patient back. So compensatory, this is the stage we need to recognize shock at, and we need to move quickly through it. Oh my gosh. Sorry guys. So let's, okay, hold on. I have to say, this is getting to be painful, isn't it? I'm deepest apologies. So really, let's look at hypovolemic shock. I'm jumping the gun a little bit, but I want to sort of clue you a little bit here. Only because we've got a patient, when we put that urine, remember we put a catheter in because we wanted a drug screen, which turned out to be negative, but we also saw that she'd been incontinent. And as soon as we put that catheter in, she had a very large amount of urine. So we're looking at what does that mean, that she's got fluid overload, but she shouldn't have fluid overload with such a low blood pressure unless potentially she's got a cardiogenic shock. Let's look at this for a second. A hypovolemic shock is caused by a loss of fluid from the body, or you could third space it to an area where you can't get it back. So a massive ascites, sudden third spacing of fluid into that ascites can cause hypovolemic shock because the fluid is in a place where you're not able to retrieve it back. When we go into hypovolemic shock, our body is magnificent in mounting these compensations that are through homeostatic processes, and that is for self-preservation. So the goal of our body is that to keep us alive until our body can figure out where that leak is and fix it on its own. So potentially, you know, if you've got a small puncture, it can be encapsulated, something like that. In any case, the goal is to compensate for as long as we can until hopefully there is a treatment. We don't have to set those compensatory processes in place, right? We don't say, oh my gosh, heart rate go up, respiratory rate go up. That all happens through our body. And I just want to talk about that for 1 second. So it happens automatically. And let's think about this. When we've got hypovolemic shock, we've got that decrease in circulating volume, right? It doesn't mean that we don't have volume in our body. You can be very puffy and very large and with that fluid third spaced, but a decrease in that intravascular volume, right? Circulating in our blood vessels. And because we have that decrease in that intravascular volume, we have a decrease in our cardiac output. And that's going to lead to two different things. We're going to have a shift in interstitial fluid. So where we have interstitial fluid, that's going to be released. We've got a release of aldosterone and ADH, antidiuretic hormone. And so that's going to try to increase our blood volume, and our spleen is going to disengorge. So typically our spleen holds about 1 liter of blood or so that it can disengorge, and that's going to give us an emergency supply of blood. We're also going to release adrenaline, noradrenaline, and that is going to lead to an increase in heart rate and an increase in systemic vascular resistance. Remember, our tone is lost. We've got that big vessel. So that's hopefully going to increase that systemic vascular resistance if we, as much as it can. And both of those things together, that increase in blood volume and that increased heart rate and systemic vascular resistance, are going to increase our cardiac output. So both of those things are going to help us to maintain our cardiac output. Just a reminder of that sort of underlying process in any kind of hypovolemic shock, a trauma, something else. In this situation, there's more finesse because we have to think of what is the cause of the hypovolemic shock. Oh, let's put all these here. So this is just a compensatory stage of hypovolemic shock in general. BP can be normal, except septic shock, we usually see that rapid drop in blood pressure. Heart rate and respiratory rate up, cold peripheries clamming, we saw that. A decrease in urinary output, but we're not at that point where we get below 30 mils. Now, we don't have that decrease in urinary output, do we? Diminished bowel sounds, we don't have that. She's had vomiting and diarrhea. Anxious and restless, she's actually neither anxious nor restless. She's got a decreased level of consciousness. And if the person gets respiratory alkalosis, we could see some things, but she doesn't have a respiratory alkalosis. That doesn't mean she's not in the compensatory stage. It means that other things may also be going on. So let's just pay attention, okay? We're going to just continue to pay attention. Am I seeing shock? Let's look at, so what's the underlying mechanism? Am I seeing shock with this patient? Can we call it shock? Can we call it compensatory shock? I would. Compensatory to even potentially moving to progressive because her blood pressure is really quite low, 80/46, right? Heart rate 138. What stage? I'm hoping it's compensatory because there's several things working in and amongst each other. So the picture is not just a straightforward picture of shock. What type and what is the etiology? Again, lots of things are going on. It looks to me potentially like hypovolemic, but I'm not going to make a decision. And remember, I never make a diagnosis, but I'm considering everything that's happening. And what is missing? So I think that's a big question for me. What's missing? I don't have enough in this picture, right? I don't have enough in this picture. I still don't understand why I have that severe partially compensated respiratory acidosis. I don't understand that because in a normal shock, I might see an alkalosis. So what is going on? In the meantime, let's gather more information then. I don't have everything. Continuous cardiac monitoring in a 12-lead ECG, right? I've got that potassium of 5.7. I've got a patient who's got a sudden change in her mentation. Of course, I'm going to put her on a cardiac monitor and I'm going to do a 12-lead ECG. Cardiac monitor is only going to give me a lead 2. I'm anticipating I'm going to see those peak T waves and I see those. Make sure I've got an IV access, a good solid IV access, right? So you might have one, you might put one in, you might put 2 in, one for meds, one for fluid. It all depends. What's happening. We would prefer a central line if we can, an internal jugular line. is typically what we'd see in an emergency. They, for a while, we were seeing a lot of use of intraosseous line. We're going to show you that in the lab. We posted an IOU for that, but they're moving a little bit away because I think it's a high level skill prep that is necessary. Not everyone is as competent as is needed to really promote intraosseous access. Typically in a hospital, you should have success putting in a central line. Regardless, put in a line, and as an 18 gauge or 16 gauge if you can get it in the antecubital area. That's an imperfect spot for somebody who's awake and walking around and other things because you're going to occlude it. This is an emergency. We can look for a better site later. Antecubital is a perfect site for as large as you can get, right? As large as you can get, and 1 or 2. Full assessment, including a neuro assessment. I have nothing about a Glasgow coma scale. I know nothing, right? So full assessment, including a neuro assessment. That doesn't take me half an hour, right? I'm quick and I know it. I'm going to ask myself, do I have the people around me that I need? Because I shouldn't be handling this alone. There needs to be somebody here with me in the room. This is so serious that it's not even just, oh, the charge nurse knows. Someone is here with me. This is an emergency. Do I have the equipment? Well, do I have enough IV fluids that I may potentially need? Do I have, do I have a cardiac monitor? Do I have the ECG machine? If I'm not in an emergency department, but somewhere else, I would want a code cart nearby because this patient is critical. I would want stuff prepared in case we need to intubate her. Do I have medications that I need on hand? We're going to figure out what medications we may or may not need. But again, a code cart would be a good starting point. And you know what we haven't checked? Blood sugar. Critical. So when do we check blood sugar? Any patient who's difficult to rouse, and this is atypical, right? Or any change in level of consciousness, check their blood sugar. You're going to do a glucometer reading immediately, and we can send blood to the lab if we need to, but a glucometer reading is low risk and high reward. Any patient who's clinical picture, we can't figure it out, right? I'm not sure what's going on. And it hasn't revealed itself. I don't have enough information, right? Check their blood sugar. Again, low risk, high reward. Always do a quick glucometer reading, and then you can follow it with a specimen to the lab to be more accurate. And when we do Rebecca's blood sugar by glucometer reading, it's 32. So what is the normal? Normal fasting 4 to 6. For most people, it may be a little bit above that immediately after a meal, but 32 is wildly elevated. And so we're starting to see something anomalous here that is very concerning. One of the things I would do again, follow up with your daughter. Does your mom have any history of any medical problems? Has she ever had a diagnosis of type 1 or type 2 diabetes? Her daughter says no. So just because she doesn't have a history doesn't mean that the evidence we're seeing in front of us is not real. She's got a blood sugar of 32. So let's, again, tally up, right? What can go in the fine pile? What can't go in the fine pile? Let's figure out what we know. High blood sugar, increased urine output. And as we're watching that catheter, she continues to pour out copious amounts of very, very pale urine. Those dry mucous membranes, she came in very dry. She was tachycardic, hypotensive, and tachypnic. She had that funny smell. Now, not all of us can smell that funny smell from ketones. It's a very fruity odor. I don't have the genetic makeup to smell it. I'm always envious of those who can smell it. People who can smell it a mile away. Down the hall, they can smell that somebody's got is in ketosis. So she's got that funny smell with her respirations. And her respirations are not just fast, but they are deep and sighing. And remember, I said that's a specific kind of respiration called a Kussmaul respiration. She also has a recent history of upset stomach. And when we learned more about it, it was feeling unwell for a month, a weight loss of about 20 pounds. She had been vomiting and having diarrhea for the last week or so. Let's think about what's going on here. High blood sugar, funny smell that we're saying is ketones. Let's review just in our mind what diabetic ketoacidosis looks like. So in diabetic ketoacidosis, it can happen for a variety of reasons. You can be diagnosed already with diabetes, type 1 or type 2, more common type 1. And either there's an interruption in your insulin, you have an illness which requires greater insulin intake that you're not able to maintain, or lots of patients who are being diagnosed with type 1 diabetes for the first time arrive in diabetic ketoacidosis because they didn't understand what process was happening. And if they didn't seek medical care initially, they may become quite sick. So when we have an inadequate, our body is not able to produce insulin, then our body's not able to use glucose for energy, right? So we're not, the insulin is what is required to enable us to use that glucose. We're not able to process it. And so when our pancreas then doesn't make that insulin, we require on our liver to, for a little while, produce more glucose. And it's going to try to do that to feed the body, trying to make more glucose, thinking, oh, maybe the problem is I don't have enough glucose. It's not that I don't have enough glucose. It's actually that I'm not processing it. So the liver makes even more, and I have even more glucose in my bloodstream. And our body needs to then find out an alternative source of energy, right? It needs to find some way to nourish its cells. I'm not able to nourish my cells. I'm not able to get energy to my cells with glucose. So I move to the second tier. Remember, our body has so many redundancies. I move to that second tier of what's possible. And that is to start breaking down fat. And that breakdown of fat has as a byproduct a waste called ketones. And so we're breaking down fat. We are ending up with these ketone bodies in our bloodstream, and they build up. So we have a buildup of those ketone bodies in our bloodstream. And so we have both that high level of glucose. Remember, our liver is still trying to make more glucose, still thinking, I want to be able to use my first line energy, which is glucose. I just don't, it's just that there's no insulin to process it. So the glucose continues to be made. I have lots of glucose circulating in my blood. And we also have the byproduct of the fat metabolism also circulating in our blood, which is those ketones. So I have the ketones and the glucose both in my bloodstream. They're processed through my kidneys. They end up in, transferred into my urine. And it's so concentrated with both glucose and ketone bodies that my kidneys are trying to draw fluid wherever possible to clear those excess glucose and ketone bodies, right? So my body is then saying, my kidneys are saying, oh my gosh, I've got so much solvent. I need solute. I need more water. I need more water to draw in and pass. And so the body attempts to get rid of all that extra glucose and those extra ketones by drawing more fluid in and then passing that through urine, right? So a lot of water can be lost. We can end up with dehydration that can become actually hypovolemic shock, and depending on how very significant that ketoacidosis becomes. So you've got not just ketosis, some people go into something called ketosis when they're on those keto diets. Ketosis and ketoacidosis are entirely different. In ketoacidosis, we do not have the ability to use glucose. And so our body continues to make that glucose. And not only do I have those ketone bodies circulating in my bloodstream, but I have that glucose. So I have so much solvent that my body uses as much water as it can use to try to pass all of that, get that out of our bloodstream through creating large volumes of urine. And that is called osmotic diuresis. So I'm actually diuresing, getting rid of tons of fluid because of that osmotic pull, right? All of that solvent, all of those particles are drawing fluid in to be able to pass that, to try to rid them from the body. So let's take a second and try an SBAR report. And we always start with the I, which is introduction. I think ISBAR is so critical because it is not just about how to report something, it's about how to think, right? So always going through this in your head, ISBAR thinking and ISBAR reporting. Introduction, hi, I'm Sue, I'm working, wherever. I'm working in the emergency department today at the outpost. Let's say there's no physician there because I have to have a reason to give an ISBAR report. Situation. What's the situation? I'm going to give you a second. I want you to try this. I'm going to give you a second or pause. Okay, so I'm going to say I have the situation, 35-year-old woman came in with decreased level of alertness. She is hypotensive, tachypnic, and tachycardic. She has a blood sugar of 32, a potassium of 5.7, and a severe partially compensated metabolic acidosis with a pH of 7.05. Good enough. I think that's good enough. Do you notice I didn't report all the values of everything? Her sodium was fine. Her chloride was fine. I didn't talk about those. Even the other values that were abnormal in the ABGs, I didn't talk about them, right? So I've already said severe partially compensated metabolic acidosis. The critical one we want to talk about is 705. That's going to communicate the degree to which our level of concern is. I haven't yet told her vital signs. I think at some point I probably in situation could clarify that a little bit more effectively. So if I were to say she is hypotensive, tachycardic, and tachypnic at with vital signs of 138, 28, and 80/46. So I've been more specific. Background, so I'm going to go on. Do you want to stop for a second? I'm going to pause for a second. You pause the screen if you want to try it yourself. It's so important to be able to do an ISBAR report. Okay, starting again. Background, 35 years old, otherwise well. Daughter says, feeling unwell for a month, 20-pound weight loss, increase in abdominal symptoms with nausea, vomiting, and diarrhea for the last week. Background is really effective. Assessment, I can do some more of my assessment, and it may be that I provide some more of my assessment there. But I think the focus for me is going to be, it would appear that she is in diabetic ketoacidosis. I am not making or communicating a medical diagnosis to the patient or their family, but in speaking with a physician, it's a fine line here because it is ridiculous not to call it what it is. So it's finding that balance in communicating within the team. I would say I'm wondering if this is a new onset diabetes with diabetic ketoacidosis presentation here, with hopefully an early stage compensatory hypovolemic shock. Recommendation, she needs what? I'm going to stop again. Recommendation. Think about it and we're back. Okay, recommendation. Intravenous normal saline bolus to blood pressure. In this case, I'm going to actually provide normal saline boluses titrating to blood pressure. So I would probably expect we're going to have a liter wide open and then look at her, reassess her blood pressure, and then follow up with a liter. She might even need more than 1 liter. I'd have to see what her blood pressure is, but she would start a normal saline bolus wide open, followed by further orders. She needs cardiac monitoring. She needs so continuous cardiac monitoring. She needs vital signs, probably Q15 minutes. She needs blood sugars Q1 hour. She's going to need an insulin drip. But before we start that insulin drip, you're going to want to get that first liter of fluid into her at least, right? Now, okay, so you're getting a sense of the recommendations. What if the doctor says, with all of these recommendations, and let's give her something to lower her potassium because it's 5.7 and that's critical. What do you think? Well, we always do want to correct a elevated potassium. The challenge is, in this situation, I know that there is a relationship between insulin and potassium, and I need to know that. 5.7 is a critical potassium. But let's say I give her something to bring down her potassium. There's a couple of different things I can do. One is I can give her something called Electrolyte. A patient would drink that, and that's going to bind with her potassium, and she's going to be able to pass it. But if I start an insulin drip, right? She's got a blood sugar of 32. We're going to start an insulin drip and titrate that as well. Once we've given that full, a little bit of a bolus, probably that first liter, we're going to start an insulin drip. If I lower her potassium with something like Electrolyte before I start an insulin drip, and I know that a side effect of insulin is that it drives potassium into the cell. So I've got that extracellular potassium, which is 5.7 in the serum, but that insulin is going to drive that potassium into the cell, so it's not usable. I actually could be giving her a hypokalemia. And even without correction, she could end up with a hypokalemia. So in this case, it is making sure you understand all the effects and side effects of things. And in this case of when we're looking at those electrolytes and hypovolemic shock caused by DKA, I see that 5.7. I know that's a critical value, but I also know the process of treatment for the underlying cause is going to correct that. And I need to be careful that I'm not overshooting that. Does that make sense? I guess the point I want to make, and I know this makes people uncomfortable, is there's not one rule for everything. So under normal situations, I'm always going to be looking to correct that potassium of 5.7. In this situation, I know that the underlying process of treating her DKA and her high blood sugar, which will involve infusion of insulin, is going to have an impact on that circulating potassium. And it's going to bring it down. And so if I also use other mechanisms to bring it down, and it comes down through the treatment, I may be overshooting where I need to go and end up with a hypokalemia. So I would just say, just be very cautious about what we do with that. Sometimes we look at something called calcium gluconate, and we want to just make sure that we sort of protect the heart a little bit from the effects of that high potassium while we're waiting for that to be corrected. Calcium gluconate only lasts about 30 minutes, but it allows for some protection while that potassium is coming down. Sometimes give it, sometimes don't. So that's just a question. If I was giving a recommendation, I'd say I wouldn't say we should give it. I would say, is this a situation where we would consider calcium gluconate? I would just ask. I wouldn't wait for someone to recommend it. I'd always just clarify, want it or don't want it. So let's see my tally up. IV normal saline bolus to rehydrate and bring up her blood pressure. Insulin drip to bring down her blood sugar, but I'd give that first liter wide open, which will take no time at all through a central line. Before it would run wide open before I even get the insulin drip ready to go. I'm going to do Q1 hour glucometer readings. That's an order tells you about the minimum time that you can do something. Does Q1 hour glucometer readings mean that I can't do it more often? No, but it does. You have to give a little bit of time to see if that blood sugar is coming down. Continuous cardiac monitoring, which is going to give me continuous vital signs. I'm probably going to check her blood pressure every 5 minutes to start. Once she's in the ICU, I can just check that continuously, look at her mean arterial pressure once we've got an art line in. But for now, I'm going to probably doing her blood pressure every 5 minutes. That calcium gluconate we talked about. Critical recommendation, observe potassium, repeat that potassium level every hour, not to treat the high K, as insulin will drive that into the cell and that K will drop, right? So one of the things I would say, if somebody asked me to administer something to lower her potassium, I'm going to have to say, aren't we going to find ourselves, blah, blah, explain that. And I think you're not going to have a problem with that. And then finally, this patient needs to be seen immediately. If I'm in the emergency department, of course, I've got the physician or the nurse practitioner with me. If I'm somewhere, let's say in outpost nursing, I've got telemedicine, and I'm going to be on the line with somebody if there's not a physician or a nurse practitioner in the outpost. If I am on a floor, probably something like this wouldn't happen immediately. But regardless, the patient needs to be seen immediately. Oh, here's a great YouTube. It's just a nice little YouTube. It's going to go over DKA as a medical emergency, and I hope you find it valuable. It doesn't really focus on the shock element, but just that whole process of DKA. My goodness, given how many times I stopped and started here, I think that will be more cohesive than me. Yeah, I hope that was helpful. I feel a little bit more frazzled when I finish this than when I started. I am going to do my very best to try to find a way not to have interruptions in the future, but I just also have to say, I think we're all kind of living a parallel process and doing our best. So today, this was my best, and I hope you found it helpful.